Hello, thank you so much for joining us. My name is Tamara Morse Todd, and I am an emergency medicine physician with Intermountain Healthcare and also a simulation facilitator. I have with me today Dr. Louisa Todd, also an emergency medicine physician. Hi, we're the doctors Todd. And we have a simulation facilitation group of Dr. Rob Bryant and Dr. Sean Slack to bring some urgent points to review for the COVID resuscitations within the setting of the pandemic. Thank you for being here, Dr. Todd.
Yes.
So I heard you had an interesting case.
Yes, I did. This was a few weeks ago. I had a gentleman that was known COVID positive who'd gotten sicker at home come in. Was requiring a little bit of oxygen, looked pretty stable for the floor, had him admitted, and then unfortunately he had a pretty acute decompensation. And it was a surprise, and there was a resuscitation involved, and afterwards, as often happens with these high stress cases, you think back and think, ooh, there are things I would have liked to have done differently.
Sure.
And so that was sort of the impetus for our COVID simulation and this project that we're doing.
Wow, just kind of stressful replaying it over and over. And what a great case to bring for a simulation to think about a teams-based approach.
Absolutely, yeah.
So what were some of the barriers you encountered in this unique resuscitation?
Yeah, so, as I mentioned, we, sometimes you have a patient admitted, you kind of got that ball rolling, you sort of think, okay, that guy's going to the floor, and, he sort of decompensated, was in significant respiratory distress, needed intubation. The staff had some struggle, myself included, getting the PPE on. And, obviously in the era of COVID, you don't want to just rush into the room just with a basic face mask and eye protection on.
Even though it's so natural.
Right. So you want to get in there quickly, but you have to think about your safety and the staff safety. So the PPE was a barrier. The communication, once you're in all of either the PAP or the N95 and everyone's gowned up, it's difficult, it's loud. Exactly.
Fan, yeah.
And it's, sort of difficult to see people's faces and effective communication gets more challenging.
Absolutely.
The intubation was also challenging, thinking about when, holding compressions during intubation. There was struggle with the viral filter, getting the viral filter, making sure it was in place. So it just kind of, adds a whole other layer of complication to a already complicated resuscitation.
Totally. So a resuscitation at any moment is stressful. Adding in a few extra steps that are required specific to COVID-based intubations. And then the emotional stress of keeping me safe, myself safe, my staff safe, and our families safe, all makes it something unique.
Yes.
All right. Yeah. So from this case, we bring the simulation center to you to help to highlight a few key things. So number one, we want to explore effective communication strategies for team-based acute resuscitations while wearing PPE, which is stressful and loud and difficult. We want to review current Intermountain COVID ACLS guidelines and emphasize what are the unique points with airway management while also keeping our staff safe. And finally, we want to showcase the benefit of teams-based simulation approach for practice. How can we prepare for these low-frequency, high acuity events to ensure that we're providing the best patient care and also keeping our team safe?
Yes.
Are you ready to give it another go?
I'm ready. Let's do it.
Hello, sir. My name is Erin. I'm your nurse. How are you doing? Sir? Find Louisa Todd.
Finding Louisa Todd. Hiya.
Hey, Dr. Todd, could you please come and assess your patient, the one that's waiting to be admitted that's got the positive COVID results? He's desatting and he's less responsive, and I think that you may need to bring our team with you.
Oh, okay, yes, I'll be right there.
Thank you.
With an arresting patient, our first inclination is to immediately intervene. However, we must retrain our thinking and always remember to have appropriate PPE in place before providing care. We recommend implementing a rapid PAPR protocol. This will ensure the necessary equipment is prepped and ready to go. Staff safety remains priority one, and delays in patient care are minimized. Okay, I've got RT with me here too. So just not doing as well, huh?
No.
Okay, is he responding at all to you?
Not really.
Okay. Sir, how are you doing? Yeah, he was doing really well just on a couple of liters before. Let me just take a quick listen to him here. Okay, So, Tamara, will you turn up the oxygen just all the way?
Okay.
And then let's put a non-rebreather over that as well, just to really oxygenate.
Got it.
Yeah.
Second access on him.
Okay. Yeah, and he's definitely, a second line would be great. He's definitely way less responsive than he was, so I'm thinking we're probably heading towards intubation.
Anything else?
Yeah, so I think I'm gonna try to do a video, the glidoscope intubation. I'd like to get the difficult airway stuff, a 3.0 LMA in case we're having difficulty ventilating him or if I'm having difficulty intubating him, and then just in case, if someone can grab me an 11 blade and an extra bougie in case we had to do a cricothyrotomy.
So difficult airway card, 0 LMA,
Yes.
and then a love blade and a bougie.
Yes.
I will grab that.
Thank you.
Dr. Todd, I have a bougie available. I
Okay.
have a 7 and a 7.52.
Okay, great.
I've got a 3.0 Mac.
Great,
for
yeah.
DL. And I heard you mention you want glidescope as well?
Yes, I want to start with the glidoscope since
Okay.
we know he has COVID.
Okay.
That's how I would ideally like to intubate him, but I want my backup.
I have the difficult airway card out here ready. I have your LMA and I have 11 blade scalpel with a bougie as well.
Okay,
I'm
great.
here to help.
Great, thanks. Yeah, Kate, if we could just keep you here, because
The equipment review will be predicated upon the intubation plan. There should be at least a plan A, plan B, and plan C, and for a patient that's at high risk of surgically inevitable airway, a plan D. Plan A should always be video laryngoscopy, so we'll have a glide right stellate loaded on an ET tube as plan A. Plan B would be direct laryngoscopy, so we would have our direct laryngoscope available on the table. Plan C would be placement of an LMA, so we would have that on the table also. Depending on the patient's risk for need for surgical airway, the cricothyrotomy rescue airway pack can either be in the room and on the table, or outside of the room, available to be brought in by the runner. This kit contains everything you would need to do a surgical airway. It has a number 10 blade, a pocket bougie, and a 6.0 ET tube. The team will also review the BVM to ensure that we have the HEPA filter and end-tidal CO2 connected in correct order, and to ensure that the PEEP valve is in place.
Do you want a viral filter?
yes,
Okay.
yes, that would be great. Thanks for reminding me. So we need the HEPA filter on there.
Okay.
I think we also need a PEEP valve.
Okay.
So if you can have that available as well, and then it looks like you're getting your end-tidal CO2, so that's great.
Okay. Aaron, could you help me untangle that? And put it on the monitor? Thank you.
Okay. And then, Aaron, if we do need to intubate this guy, which I think we are going to need to, let's get the pharmacist on telehealth so that they're available to help us with meds as needed. I think, so he's 86 kilograms if I remember, so I think I'm going to do rocuronium and ketamine.
Okay.
So if we can get, let's see, 120 milligrams of rocuronium and then 70 of ketamine, and maybe we can talk to pharmacy about getting those medications for us.
Okay, so 120 of rocuronium and ketamine. I'll
Yes.
insert that onto that.
Okay, thank you. Oh, that looks weird.
It looks like he's gonna be there.
Okay, Kaden, can you
Yeah.
do a pulse check for
Sure.
me?
Just go ahead and pull
Just
the
gonna check
out.
out thermometer pulse. Okay.
Yeah,
I'm not feeling a pulse.
Okay, I'm dropping the bed.
Okay, I'll pull the pillow out. So Kaden, let's go ahead and start CPR, please. Okay,
Dr. Todd, would you like the BVM?
So we're going to review basic BVM setup, with the key point being that the viral filter goes onto whatever is attached to the patient to protect providers from any viral secretions coming from the patient. So if you're providing BVM ventilations or passive CPAP prior to intubation, viral filter goes on the BVM mask. If you've just intubated the patient, viral filter goes immediately on the ET tube. Order of setup: BVM mask or ET tube, then viral filter, then end-tidal CO2 detector. Key point of this being that we want direct confirmation that ventilations are being delivered, and if we're having to provide BVM ventilations between intubation attempts, we want to see that that breath is being delivered and get confirmation that there's no leak around the mask. After this, BVM attaches, and then every BVM should have a PEEP valve attached, and that can be dialed up to between 10 and 15 centimeters of water. Benefit of the PEEP valve is that between intubation attempts you get faster and better reoxygenation, and after intubation you get better return of normal O2 sats. So this is how it would look when we're providing passive CPAP prior to intubation with apneic oxygenation running. After intubation, or after tube delivery, ET tube gets delivered directly onto the viral filter.
And do you want me to bag?
What I'm going to have you do is a two-hand technique,
Okay. 1 second.
and not bag, okay?
All right.
And then just make sure you have the oxygen, the apneic oxygenation going with the 15 liters on the nasal cannula.
Okay, apneic oxygenation is wide open.
Okay.
I have the BVM on with the viral filter.
Okay.
Tidal CO2 and the PEEP at 10.
Great.
Okay.
Okay, that's perfect.
I have a good seal.
So Aaron, it looks like you're setting up the pads. That's great. We're going to go ahead and defibrillate this patient. So when you're ready, charge to 200 joules, and then let us know when you're ready to shock.
Thank you.
Okay, I am going to go ahead and intubate. So let's switch places, Tamara. I'm going to go ahead and take over for you here.
Okay.
Go ahead and kind of slide behind me.
You got it? Okay. Sliding behind.
Okay. I'm going to come around here.
Take out your cloth here,
Okay.
ready to shock this patient.
Okay.
I'm going to charge it to 200.
Okay.
Everyone stand clear. Shock delivered.
Okay, resume CPR. Okay.
You guys need to draw up a milligram of epinephrine.
Yes, please. That would be great. Let me know when that's been given. Okay, I'm going to go ahead and intubate. Kaden, I am going to have you hold CPR while I intubate.
I have good misting of the tube.
Good. Okay, great. Let me
Chest
just take
rise.
a listen here. Go ahead and give me a couple of... Okay, got equal. I got bilateral breath
I'm going to
sounds.
finish this round of CPR and have Aaron switch me out.
I have good waveform on capnography.
Okay. Okay, good, good, you guys.
All
So I'm
right, Aaron, are
gonna
you ready to switch? All right, go.
get CPR in progress. We have him intubated. Looks like the tube's where it's supposed to be. Does anyone at this point have any other suggestions, ideas on what we should do?
Maybe some ISACs and an ABG.
I think that's a great idea. So we'll get those going.
And tidal CO2 is increasing, Dr. Todd.
Okay, that's a good sign.
We're up to 24 from 9.
Okay, that looks more organized rhythm. So why don't we see if we have a pulse?
Great.
Go ahead and hold on CPR, Aaron, and Kate can check for the pulse.
I have a palpable pulse.
Okay, great.
I'll go ahead and recycle up pressure.
Okay.
Seconds.
97 over 62.
All right, well, nice job, team. It looks like we're heading in the right direction. I'm going to go ahead and call the ICU and get this gentleman up to the ICU.
Wow, that went really well.
Thanks, that felt a lot better.
So can you summarize what was happening in the case and how it went?
Yeah, I mean, it just felt really good to do that case again and practice the resuscitation with good communication, good PPE, much more controlled intubation. And it's interesting how subtle changes like that can make such a big difference in a resuscitation. And it's just great to get to practice it with the actual team, with our nurses, our respiratory therapists, the pharmacists. It felt really good. We have a great team.
Absolutely, and both during the case and after the case, I really saw how that team came together and felt more empowered to manage
Absolutely.
a stressful situation. They were using closed loop communication. Hey, Louisa, can you grab that epi?
Tam, I got your epi. I'm giving it now.
And using that PPE, there was no risk to the staff during that case. And it was just really nice to see.
Well, thanks. It felt good.
So our hope is that you take what you've seen here and think about your department. How does your COVID resuscitation look? Are there things that you could take from what we've shown you, or maybe things you could teach us to help us improve our level of acuity and our resuscitation efforts for COVID codes as an Intermountain organization? Before your next shift, take a few minutes, think about what you've learned. Prep with your department at the beginning of the shift. Okay, how are we going to respond if there's a COVID code? Practice using closed loop communication on all your patients. Make it feel natural. Try to keep yourself and your coworkers safe using the updated Intermountain ACLS guidelines for COVID cardiac arrest. If the patient is having active compressions, make sure you have early intubation. Pause those compressions as the tube is going in, and ensure a viral filter is in place before resuming.
Absolutely. Yes, thank you. Great summary. And I really think this has shown how simulation learning can be for all roles and learners in the emergency department. And keep an eye out. We're taking it on the road. Got some upcoming in situ training sessions around the state. We hope to share what we have learned, but also want to learn from all of you. And please feel free to reach out to us directly if you are interested in hosting an in situ simulation training in your department.
For those COVID cardiac arrests.